Hi guys, and welcome to our environmental emergencies lecture. Would like to call it anything but environmental emergencies. I've been calling it environmental allergies and environmental injuries. For some reason, this is like the biggest tongue twister in the world for me. Environmental emergencies, however, is what we are going to be talking about, which is sometimes some rare occurrences, but definitely things that we need to be aware of and things that we need to know how to manage as a nurse. So that falls right along with our objectives today. We're going to discuss the incidents, signs, symptoms, and emergency management of specific emergent conditions, as well as the nurse's role in these emergent conditions. We're going to go right on in and talk about heat exhaustion. We're going to talk about heat stroke and heat exhaustion. Heat exhaustion first. This is the more minor of the symptoms that we're going to have here. This is a syndrome that's caused primarily by dehydration, inadequate fluid and electrolyte intake, and, frankly, overexerting ourselves on even a regular day or being exposed to warmer temperatures environmentally. The symptoms generally have a rapid onset and can occur actually in hours to days there. It's very common in our very young and very old who have skin and fat distributions that make them more vulnerable to this, as well as mobility issues that may prevent them from removing themselves from situations there. And if left untreated, heat exhaustion may turn into heat stroke. So we do need to hop on these, but just, not with as much emergent care as our heat strokes. Signs and symptoms of our heat exhaustion are going to be nausea and vomiting. Patient may exhibit some anxiety. They may even have general malaise, so the opposite of anxiety, right? You will notice a core body temperature of a very large range, so from normal 98.6 clear up to under 11 degrees. So this is heavily reliant on what's going on with our body and the signs and symptoms we're exhibiting. The patient may also have some headache due to some dehydration and dehydration. They may have orthostatic hypotension. So at this point in the game, I'm sure most, if not all of you guys, have been tasked with the opportunity to perform orthostatic blood pressures on at least one patient. In this case, we take a pulse and blood pressure in the lying, the sitting, and standing position. If the patient drops roughly 20 systolically and has some tachycardia with the postural changes, so from lying to sitting and then sitting to standing, we can anticipate that this person is dehydrated. We can also anticipate that they're going to be a fall risk and a risk for syncope, and we should take those appropriate measures while we're in while they are under our care. I have bolded up here that a patient will have heavy perspiration, so lots and lots of sweating, and the reason why I have this bold is because this is the opposite that occurs when a person has heat stroke. They will have no sweating. So if they're sweating, we can still kind of consider them under that realm of the heat exhaustion as opposed to the heat stroke. Patient may also exhibit signs of muscle crampedness and incoordination and even syncope. All right, so treatment for our heat exhaustion, folks, is going to be to perform some basic supportive care. We're going to take care of those A's, B's, and C's, right? First is airway. If the patient is, vomiting, we need to make sure that their airway is protected, and then we will provide them with some antiemetic, whether it be PO or IV, because at this stage of the game, the patient is likely to be able to take oral. Sometimes they may not, and due to their, fatigue, muscle cramps, that kind of more how we feel is going to, progress to an emergent type situation, we may be more aggressive or less aggressive. And we're going to obviously have the patient or bystander rest in a cool place, and fluid replacement and electrolyte replacement, whether it be IV or oral. So fluids, lots of water, and electrolyte replacement like a Gatorade. Heat stroke. There's two different types of heat stroke. One is exertional or exercise-induced heat stroke. I'm telling you guys, sometimes exercise isn't good for you. This results from strenuous physical activity and a hot environment. And then our non-exertional or non-exercise induced heat stroke is also known as our classic heat stroke. This occurs in individuals who are vulnerable to high temperatures. So this is a patient that has had heat stroke or heat exhaustion in the past. They are actually more vulnerable to obtaining a heat stroke. And then, obviously are very young and very old. We'll go through like a couple more risk factors here in a minute. Heat stroke is a true emergency medically, and we do not delay treatment, so they need to be seen in the emergency department. Okay, so once again, heat stroke can be caused by strenuous activity in the hot climate or environment, or just exposure to the hot climate environment, and can be precipitated by medications that affect heat production and regulation. Oh my goodness, most of these are like psych meds, right? So it all comes back to mental health, I'm telling you. So we have our thyroid medications, especially like our levothyroxine, that's going to help us boost up that thyroid production there, as well as our Haldol or haloperidol, our antihistamines and anticholinergics, our phenothiazides, and our propranolols. These are all potential medications that can affect heat production and regulation. So signs and symptoms of our heat stroke is a core temperature of greater than 105.8, very, very hot, right? The patient will also exhibit nausea, vomiting, diarrhea. They will be tachycardic and tachypnic, and as we know, we can't really sustain that for too long before we start having lots of metabolic compromise and respiratory compromise on the body. So, well, like I said, this is quite an emergency. The patient might also exhibit hypotension, or will exhibit hypotension, decreased urine output. They may have an altered level of consciousness, seizures, and they may have dilated and unresponsive pupils. They might have some coagulopathy issue. This is as a result of an increased myoglobin degradation there, and they may have absence, or they will have absence of perspiration, just like we had spoke about. We are going to be performing some aggressive treatment with our heat stroke victims. The treatment includes supportive and advanced care. We're going to consider those A's, B's, and C's first of all, and then cool that patient rapidly. We're going to remove their clothing and put ice packs onto their core, so not their extremities. We are also going to control shivering, and shivering is our body's response to try to increase our temperature, but we don't want it increased, right? So we're going to try to control that shivering, so we can actually have some warmth, or like in this case, the patient has socks on their hands and feet, has socks and gloves on their hands and feet. That might help with the controlling of shivering, as well as a neuromuscular blockading agent such as succinylcholine. We might give the patient some analgesia like fentanyl or Dilaudid or morphine, but one of the analgesics that we actually do use is Demerol. that helps control the shivering. Demerol is an opioid that was used widely many years ago, and it's just fallen out of favor due to its ugly side effects for most people. But this is actually a case where Demerol is needed, or preferred, I should say. And then we will probably most likely be sedating that patient as well to help control that shivering. We're going to be administering IV fluids at room temperature, and then we're going to monitor the urine for any myoglobin. That's the release of, or what's left over when muscle breakdown happens, and that is just widely not accepted within the kidneys, all of this big myoglobin that's trying to go through there. So our kidneys don't like this story, and so we are going to really monitor for that acute kidney injury. We're also going to replace their fluids and then monitor for any kind of clotting factor for this patient due to their high risk for their coagulopathies. So we're going to totally switch gears into our hypothermia. This is defined as a core body temperature of less than 95 degrees. Wow, that's quite cold, right? Body heat loss can be caused by convection method, which is the way the air moves around us, as well as conduction, which is direct contact. I should be having those little bullet points be below conduction. I apologize. This is where like I said, with direct contact, so our normal heat loss by conduction is about 2%. But if we have wet clothes on, all of a sudden our heat loss is going to be about 10%. And then if there's any kind of cold weather submersion, all of a sudden we're looking at 50%. So wet clothes and water submersion are going to play high and be some high risk factors for these patients. We can also lose heat by radiation, where our skin is exposed to an environment, as well as evaporation. Evaporation is where water is converted to a liquid or gaseous state. Three different degrees of hypothermia include our mild, our moderate, and our more severe. And in our mild form of hypothermia, our temperature is going to be anywhere from 95 to 91.4 degrees Fahrenheit. And in this case, we are doing lots of compensating. So our vasculature is going to get all nice and toned up. And as a result, we're going to have high blood pressure. We will also be shivering and once again have all these like high compensatory problems like rapid breathing and a rapid heart rate. Like I said, those constricted vessels. Patient might be exhibiting some neurological issues such as apathy, fatigue, impaired judgment, and lack of coordination. When we get into our mild degree of hypothermia, this is where our temperature can range anywhere from 91.3 degrees Fahrenheit to 80.6. And the patient at this point might have an irregular heartbeat. And at this point, we're, looking at loss of compensatory mechanisms. So our heart rate will slow down as well as our breathing. Once again, we'll have some neurological issues such as a lower level of consciousness, decreased reflexes, may experience some dilated pupils, and because the vascular tone has decreased, we will also have low blood pressure. And then our severe form of degree of hypothermia, this occurs at below 80.5 degrees Fahrenheit. The patient will exhibit labored breathing. They will have non-reactive pupils, and at this point in time, it's hard to get back, so they will likely experience heart failure, pulmonary edema, cardiac arrest. We do obviously have some at-risk populations for our hypo and hyperthermia, and this really applies to all of our patients both hypo and hyperthermia, except at the very last one, trauma patients. They're more likely to be exposed to the hypothermia. hypothermic situation. So our neonates, they have inadequate body fat. They do have some brown fat is what they call it, which helps their core a little bit, but they just don't have enough body fat to help them out as far as thermal regulation goes. And then they have the inability to shiver. So our neonates, or patients below 30 days, they don't shiver. And they also obviously have the inability to seek warmth if they are cold. If I'm cold, I put a sweatshirt on. Neonate can't do that. Then our elderly, due to polypharmacy, varying medications that they're on, like as described earlier, loss of body fat also in our elderly, as well as some innate cardiovascular changes that can occur, as we age with our cardiovascular disease. They're more at risk for hypothermia. Then our alcoholics also have risk due to their poor nutrition status and let's just be honest, the lack of proper decision making there. And our homeless populations are definitely at risk due to their environmental exposure. And then the trauma patients, we want to keep those guys nice and warm. I think I've told that to you a couple times by now. So with our hypothermic patients, this is the treatment. We're going to rewarm their core. This is key. So 3 categories of rewarming. This includes passive, spontaneous, and active. More on that in the next slide. Active can further be broken down into external active and internal active. So some key principles that you need to know in regards to the hypothermic patient is that VFib will not respond to conventional ACLS interventions. So that would be shocking, right? So if the patient is below 86 degrees in Fahrenheit, we do not continuously shock them because we need to warm them first. The priority is to warm them first, and then they can respond to the shock. They have just such a low level of metabolism, and then really, we need to discuss the problem at hand first. The second or the primary reason why they are having a VFib. We're also going to replace their volume. Obviously, we're going to use warmed fluids. We're going to core that rewarming the core is the key to preventing rewarming shock. So rewarming shock is a phenomenon that's not really well understood, but basically as we rewarm the patient, they can go into a profound shock where they can be very, very hypotensive. So instead of rewarming the extremities, we need to make sure we're rewarming the core there. The hypothermia results in decreased metabolism of drugs, so we should be giving our medications judiciously. Once again, we should be really, really concentrating on getting this patient warm, and even secondarily worrying about some of our ACLS drugs. There is a saying in the emergency department that the patient is not dead until they are warm and dead. So hypothermia actually has, with our decreased metabolism, this is actually a protective feature for us to decrease our metabolism. And so we should not count out that patient until they are warm. Okay, quite a few different ways that we can rewarm a patient with our passive or our spontaneous rewarming. The objective for this one is going to be to minimize the heat loss, get them out of that heat loss situation, whether it be conduction, convection, evaporation, otherwise. We're going to remove them from their cold, maximize the heat production. We're going to dry the skin, cover with warm blankets, protect from airflow, cover their head where we experience quite a significant amount of heat loss. Advantage of this is it's pretty easily accomplished. We can even take care of most of this as a someone who cares for somebody outside of the emergency department, and of course it's pretty inexpensive. Disadvantage of this is the patient must actually be capable of thermogenesis or creating some heat within in order for this to work. So there is a point where the patient just really is not going to be assisting with their own thermogenesis. And shivering does stop at 89.6 degrees, so that might be our level that we stop. Active external is going to be heating that patient externally, whether that's with heating blankets. We can use our bear hugger as your peer had helped us out in the use of, and we can use warm water immersion, so dunking them into warm water, which is basically like hot tub temperature, anywhere from like 99 to 104 degrees. The advantage of this is it's pretty rapid and it's non-invasive. Some disadvantages are the patient may have increased mortality. This is from that rewarming shock, right? And they may have inhibition with their shivering. There's a potential for them to have a skin burn, such as in the case of if we use too hot of object. And then our active internal rewarming, this is where we're internally rewarming that core. This is utilized with heated, I can't see, neither can you. What's going on? Let me pause real quick and see if I can get the slide moved. Okay, that looks better. So we can use our heated humidified oxygen. This is delivered, either with a mask or intranasally. We can actually heat that humidified oxygen. We can use warm IV solutions. Peritoneal lavage. So when we did our talk about our abdominal injuries, we talked about the diagnostic peritoneal lavage, where we're inserting fluid, pulling it back out, and seeing if there's any blood in the peritoneum. And this gives us an indication whether we have peritoneal injury. But a warmed peritoneal lavage, in this case, we're going to be infusing warm fluids right into that peritoneal space. This is an example of core rewarming internally. We can also irrigate any part of the GI system with warm fluids, such as through an NG or OG tube or a rectal tube. We can be irrigating with warm fluids. In addition, this is getting quite severe. We can do extracorporeal circulation, so those heart lung machines, which we're going to be replacing cold with warm there, as well as cardiac bypass through the use of a rapid infuser, and even hemodialysis, where we're replacing cool blood with warm blood. Obviously, this is going to be the most rapid means and the most invasive, expensive, and may require advanced skills. I'm going to go ahead and say it will require advanced skills. Okay, going down to our frostbite. This is a condition that results when ice crystals, this is crazy, right? Form in the cells and extracellular spaces, and this causes direct cellular damage. Indirect damage may also occur due to vasospasm and arterial thromboses. So as we have a vasospasm and an arterial thrombosis, we're just not getting enough circulation to the site. Damage is irreversible for our frostbites. Irreversible. So we have our superficial and our deep, and these go without having to give too much of an explanation, but the superficial usually involves, just our fingertips, ears, nose, cheeks, or toes, those little parts of us that are susceptible to getting cold, right, on a cold day. And the skin usually retains some kind of resistance when you press on it, so the affected areas of the body may feel cold, hard, white, numb. And in our deep frostbite, this is going to involve our deep structures such as our muscle, fat, bones, tendons, and obviously our skin. This produces vascular and tissue changes that result in cell injury as well as cell death. And like I said, that portion is irreversible. Factors of frostbite include ambient temperature, so we can have frostbite even in ambient temperature. A wind chill factor must be considered as well, and factors obviously also include the duration of exposure, how long we're exposed there, and if there's any contact with moisture or any metal objects, that's going to be our direct, right? So we'll have quite a bit more heat loss based on that. And then, how we are protecting ourselves, the type and number of our clothing layers. Signs and symptoms of this may include burning pain followed by a feeling of warmth, and then numbness to that affected area. So, burning pain, warmth, then numbness. The patient might also have white or yellow-white discoloration of the skin with a waxy type appearance, almost like our superficial superficial partial thickness burns, or our partial thickness burns, I shouldn't say superficial at all. And then swelling and intense burning accompanied by thawing. Blisters usually take about 1 to 7 days after the event to begin occurring, and the patient may have edema in the affected extremity, and this can last for months. Severe discoloration, such as, that black necrosis type looking skin, is going to be a late sign of our frostbite. Treatment for our frostbites are going to be to protect the injured area from further damage. So remove that person from the situation that's causing the frostbite. We might do an immersive therapy to the injured area in circulating water that's going to be anywhere from 98.6 to 104 degrees. We should not be rubbing the injured part due to the tissue changes. This can, further damage our skin there. And once thawed, we're going to protect that injured area and immobilize the extremity. As needed, we're going to administer NSAIDs, which can be quite great for this patient, as well as any kind of analgesics that they may need. We're also going to rehydrate the patient and assess for comorbidities of the patient, as this may not be the only thing that's going on. As we can remember, we got to look at the mechanism of our injuries, right? And TPA is being considered for treatment for frostbite, and this is to allow more circulation to that area, perfusion, which is going to aid in our wound healing. So hopefully more on that in the future. The patient may have to undergo a chirotomy to provide some proliferation of cells there for our severely vascular compromised. They also may need an amputation. This is usually delayed by 60 to 90 days until you have noticed that there is a final demarcation. So we've noticed where that necrosis is going to end. Little saying always a bunch of little sayings, right? So frostbite in January, they're going to amputate in July. All right, moving into our submersion injuries, drowning. This is the process of experiencing respiratory impairment from a submersion or immersion in liquid. There is wet versus dry. These terms are no longer used. Wet is where there's water in the lungs, and dry is where there's not as much water or little or no water in the lungs. And we're just treating our immersion or our submersion injuries just drownings or drownings at this point, not to confuse people. So 10 to 20% of drownings, the patient will have a laryngospasm, which will prevent aspiration of water. But if aspiration does occur, it may be very, very little. So as little as 4 milliliters per kilogram. 1 to 3 milliliters per kilogram can actually alter that surfactant function and interfere with gas exchange. So on our 100 kilogram patient, which is 220 pounds, if they have 100 milliliters of fluid, that can severely alter that surfactant functioning, and then obviously interfere with gas exchange, and there we go, we have a drowning victim. We also need to consider things such as if the body of water that the person was immersed in was fresh water or salt water. The differences don't affect the immediate treatment, but we need to consider the contaminations that are involved in each of those bodies of water. 1 in 3 drowning survivors may experience some long-term neurological sequelae. That's huge. Lots of neuro problems with these guys just due to anoxia, not getting enough oxygen to the brain, right? Cold water versus warm water. Cold water, just like in the case of our hypothermic patients, it's actually kind of a good thing to have that metabolism slowed down, right? It may slow that hypoxic brain injury issues, and the patient obviously also may need to be treated for hypothermia simultaneously as they are being treated for their drowning. So for our drowning victims, symptoms may vary depending on the extent of the drowning. We have to consider if there was a history of a submersion. The patient may also have respiratory or cardiac arrest, dyspnea that gets worse, cyanosis, crackles, wheezing, cough, tachycardia, confusion, and coma. These are kind of all, goes without saying, right? So our treatment just goes right back to those BLS and ACLS supportive measures. Remember, if they're cold, we need to re-warm them before we consider, a huge potential effects of our ACLS measures like medications and shocking. We will also be giving IV fluids and intubating the patient, and we will be giving them some kind of ventilatory support, such as a BiPAP or a CPAP, perhaps. This is all to get that positive pressure into the lungs and fluid out of the lungs, and this will increase our gas exchange there. We're gonna, like I said, treat hypothermia and then treat any kind of acid-base imbalances. We'll give prophylactic antibiotics for this patient. We might consider doing a gastric tube to decompress the stomach to prevent any kind of aspiration there. And we're going to admit the patient and monitor for ARDS. All right, we had talked about our fever in children, and I think we had a really great discussion in our tools of the trade assignment. regarding fever in children, so I'll keep this quite brief. This is the most common chief complaint for our pediatric population. This accounts for 20 to 25% of pediatric ED visits, so huge numbers there. A fever is defined as 100.4 degrees Fahrenheit, or right at 38 degrees Celsius. Causes include infection, viral or bacterial, dehydration, heat exposures, or sometimes metabolic disorders. So we need to find that cause of the fever in the child, right? Symptoms include obviously the fever. The patient may also experience tachycardia, flushed skin, tachypnea, agitation, and diaphoresis, which your peer went over quite well. Treatments for these guys are going to be fluids. It's actually preferred that we give the patient PO fluids, and as well as IV or sub-Q fluids. This will be based on the patient's condition. Obviously, if they're not able to adequately take PO fluids, we'll use the IV or sub-Q method. I don't know how many times I've taken a TNCC or emergency nurse pediatric course, and they always push this sub-Q method, and I've never seen it done. I've kind of asked around, and I don't think anybody's doing this here locally, but they say, we can just pop a sub-Q IV into these, or sub-Q needle into these children, and deliver fluids slowly into, they usually use kind of like that flank area on the patient. It's really quite remarkable how they do that. And then the fluid just gets kind of infused into the body, and it's supposed to be kinder and gentler on our children. But yeah, like I said, I've never seen it done. We'll also give the child antipyretic medications. This is the acetaminophen at 15 milligrams per kilogram. And ibuprofen on a patient that is greater than 6 months old, we can give that ibuprofen at 10 milligrams per kilogram. And usually, if it's given over the counter, this will be dosed so you're giving the same amount of milliliters of fluids, and that makes it easier on the parent. So if it's known that they can give 5 milliliters of fluid, then on the Tylenol, then they can probably give 5 milliliters of fluid with their ibuprofen. So this kind of decreases some confusion for our parents, just 5 milliliters of each. And then, like I said, we need to make sure that the patient isn't vomiting first. And aspirin, as we all know, is contraindicated in children less than 12 years old. Then we're going to treat the cause of the fever. So antibiotics is a potential if the patient does have a bacterial infection. Then we're going to rehydrate that patient. Fever in neonates is something totally different, and this requires a septic workup. So our neonates are considered those that are younger than 30. They have very, very recently, within the last 6 months, done some changes as far as our sepsis workup goes for our neonates, which may not include the lumbar puncture if we do find the source of the infection there, but it's really super invasive. We'll be taking blood cultures from these little guys, urine cultures, so have to do in and out catheterization on these guys, as well as getting baseline labs, CBC, BMP. We'll no doubt get an NSAID rate for these patients, as well as procalcitonin and a lumbar puncture if the source of the infection has not been identified with those measures. So lots to do with our fever patients even. All right, let's go to bee and wasp stings. I had this image in my head that I've always had this image in my head that I was going to be a beekeeper. It's not like I love bees, but I just think it would be a lot of fun. But in that case, I should be calling them by their name, and I have a hard time with it. This is the Hymenoptera. the Hymenoptera, a class of insects. This includes our bees, wasps, yellow jackets, and fire ants. Reactions can be widely varying with our bee and wasp stings, and can be local, like a local infection, and even as far as up as anaphylaxis, so anaphylactic reaction on these guys. Can also get some serum sickness, and this kind of occurs 10 to 14 days post where our IgE mediators are going to be slowly responding to this new invasion. So for our local reactions, this will be a wheal or a welt with redness and swelling. You can notice that the stinger may or may not be present at the wound site, and there may be some redness, blistering, or pustule that may form. And then the patient may also have angioedema. Had this just this week in our emergency department, where the patient had angioedema, those big old huge lips. This is a sign that anaphylaxis may be on its way. And then the treatment, it will treat the anaphylaxis if the anaphylaxis is present, and this gets treated with epinephrine, right? We're going to use antihistamines like an H2 blocker, but we'll do it IV. This includes Pepcid. So the anaphylactic reaction is our body's allergic response mechanism going into super overdrive. So we are going to try to block them with that Pepcid there. Then we'll also give NSAIDs as needed and wound care. Oh, they may be getting antihistamines such as Benadryl as well. So spider bites. There's actually 2 spider bites locally that can be, culprits for our spider bite problems. One is a brown recluse, and the other is the black widow. And most of them are actually this third cluster, which is the Must's disease. It must have been a spider. Which is usually folliculitis, or the ravenous MRSA spider. I should take that. You guys should take that one with a grain of salt, because MRSA spiders don't exist. It's just MRSA. So 80% of reported spider bites are actually erroneous. They're not spider bites at all. Multiple bite marks exclude spiders, as spiders only bite once. So if a patient does have multiple bites, it's not from a spider. Symptoms of a black widow bite, these are neurotoxic. So we have hemotoxic and neurotoxic. Our black widow is going to be neurotoxic. There's going to be pain at the site with actually a halo around the bite. The picture down below gives you a great opportunity to see that. The patient will be exhibiting some muscle cramps. The signs and symptoms will peak in about 2 to 3 hours and last for about 2 to 3 days. Unfortunately, because it is neurotoxic, the patient may have some immediate hypertension. Then our brown recluse are going to be hemotoxic, not neurotoxic, and necrotic. So there's going to be area of local necrosis at the site. You'll notice like a minor pain with bluish irregular borders. So what occurs is edema. This is immediate occurrence, followed by our erythema, which usually lasts about 8 hours, followed by our necrosis, which occurs at about day 2 to day 4 of our brown recluse spiders. The patient will also have fever, nausea, vomiting, and an eschar formation that may even require some surgery. So our spider bite treatments, we're going to ice that each of these areas. This will decrease venom absorption. We're going to also elevate the extremity above the heart and compress for pain. Compression for pain may be indicated, so we can, do a Coban type compression for these patients or ACE wrap type compression. And if the spider bite is severe, we will treat symptomatically. We can give benzodiazepines if we're in a neurotoxic state for any kind of muscle spasms, and we can also give anti-venom for some significant bites, and I'll talk to you in the snake bite slide about anti-venom. And on to snake bites. So statistics, 5 to 10 deaths annually in the U.S. from venomous snake bites. So not probably as big a problem as one might think, but there are 45,000 snake bites that occur annually in the United States, and 7 to 8,000 of them are venomous. So we will most likely find these guys in the emergency department, but we can anticipate that we'll treat these guys without them having a high risk of morbidity there, or mortality. I keep messing that up, sorry. Most bites occur as a result of attempting to handle the snake, so I think I should go without saying that we should not be trying to handle snakes. 40% of snake bite victims have a blood alcohol of greater than 0.1, so coincidence? I think not. 85% of bites occur on the fingers and hands, once again, as we're trying to handle that snake. Only 15% occur right around that foot and ankle area, as you get on into the snake's territory. 45% of venomous snakes bites are actually dry, so there's no venom that's actually injected. So even if you are, bitten by a rattlesnake, let's say, there may pretty high chance that there's no venom injected. Of 120 species in the United States, only 20 of 4 species are venomous. So we got our pit vipers, such as our rattlesnakes, copperheads, and cottonmouths, and then our coral snakes. I'm going to pretend like I have a degree in snake studies and tell you all about what might be the characteristic of a snake bite, or a venomous versus non-venomous snake bite snake looks like. So in our venomous snake, the pupils will be elliptical, except the coral snake, which is going to be round. Otherwise, they're elliptical, kind of like if you can think of our, copperhead or rattlesnake there. They've got those nice kind of almond-shaped eyes. And our non-venomous snakes, their eyeballs are going to be, their pupils are going to be nice and round. Okay, so our venomous snakes will have fangs and they will produce puncture marks. And in our non-venomous snakes, they're going to have several rows of small teeth, and it'll produce scratches instead of puncture marks. The head shape of our venomous snakes are going to be triangular, where our non-venomous snakes are going to be nice and rounded. So once again, think of that, copperhead or a rattlesnake that has a nice triangular shaped head. Presence of pit between the eye and nostrils, so there'll be like a big pit right between that eye and nostril, which gives the name pit, to our pit vipers. So those ones are going to be venomous if they do have that pit, non-venomous if they don't. And the tail and row, like the row of subcaudal plates, and our venomous are going to be a single row, and our non-venomous is going to be a double row. There's also a saying that we have found that says, if red touches yellow, he's a dangerous fella, such as like in the case of our coral snakes. But if red touches black, he's a friend to Jack. So we should not be having red touch yellow. He's a dangerous fellow. Okay, so the severity of bite, obviously, just depends on our species and the size of the snake. It's going to depend on the location of the bite and the depth of the bite. So, in other words, our muscle actually absorbs venom quicker than our fat might, or than our fat will. So, it kind of really depends on, the location and depth, like I said. Obviously, the severity of the bite is going to depend on the number of bites, if there's any venom injected, and the amount of venom that was injected. The age of the snake, our young guys are actually more apt to bite, but they will be usually contain, not be as deliberate with their venom. And if there's any kind of previous exposures, if there's a concentration of microorganisms in the mouth of the snake, that will increase the severity of the bite. Our pit vipers, you're going to have pain at the site, and that's going to be out of proportion to the puncture. So little puncture, huge pain. The patient may report a metallic or even a rubber taste in their mouth. And I have to laugh because when we give saline flushes to people, sometimes they say, oh, it tastes like pennies. And I was just thinking to myself, like, how many people are just eating pennies? But yeah, they may have a metallic or rubber taste in their mouth, and they might exhibit some oral or facial numbness, rapid onset of edema. For our rattlesnakes, this is going to be involve our vasculature big time. So our fang marks might have oozing or non-clotted blood, so a lot of bleeding out of there. The patient will exhibit some surrounding ecchymosis, and there's going to be some severe burning pain. Our coral snakes, they're going to have some like non-specific early signs, but about 12 hours post-bite, they'll have quite a bit of significant systemic changes, which include, some end organ failure there. So our snake bites, our pit vipers are going to be hemotoxic. The patient will have capillary fragility, petechiae, like I said, a lot of ecchymosis around the site. You will notice maybe some edema in the patient, as well as hemolysis and some coagulability issues, as well as a potential for the patient to go into DIC. With our neurotoxic, such as our coral snakes, the patient may exhibit some periorbital paresthesia, some pain or numbness at the site of the bite. That's, like we had said, kind of out of characteristic for the bite there, for the look of the bite. Patient might also have some neuro issues, right? This is neurotoxic, constricted pupils, muscle twitching, difficulty speaking, confusion, weakness, and paralysis. And our cobras, or our mambas, which are not indigenous to North America, these are cardiotoxic. The patient will experience tachycardia, hypotension, shock, and cardiopulmonary arrest, and not many of these people survive. I had the opportunity to go to South Africa a couple times and see some black mambas in the wild, and they say they usually call them two steps because that's as far as you go before you're starting to have major problems. So sometimes it's better to do nothing than something. So this slide says treatment, don't just do something, stand there. As opposed to don't just stand there, do something. So I'll tell you a little bit more about that, why I named that this here as we move along. We may or may not have to do some BLS and ACLS as indicated. Obviously, that's, going to be our go-to first thing. We're going to remove any constricting clothing or jewelry on the patient. We're going to immobilize the extremity at or below the level of the heart. So, very similar to our compartment syndrome, we're not going to want to get the toxin back to our heart as quickly as possible. So the extremity goes at or below the level of the heart. We're also going to run some coag studies on them and things that we don't do. So this is why I have don't just do something, stand there on the title. So we're not going to use ice for this patient. We're not going to use tourniquets. So if the patient gets bit, we don't use a tourniquet on them, and we don't suction out the wound, with our grisly skills. So we do not do these things. We do want to, however, cleanse the wound, give it some analgesic for the pain. Like I said, that sometimes the pain could be a lot higher than it appears like it should be. We're going to monitor the patient for at least 6 hours to determine any kind of need for anti-venom. So anti-venom for our pit vipers, it's a polyvalent immune fab, or crow fab is what it's called. Things can change throughout people's locations, and so if you find yourself in an emergency department working throughout the country, you should definitely inquire as to what kind of anti-venom they have in their area. So basically they take venom from these snakes that were born in captivity, really, and inject it into sheep, and then use plasma from these sheep in like New Zealand or something like that, and create this recombinant called crofab there. Regardless of how it's done, we will want to start right away on this patient. So we'll want to start within 4 to 24 hours after the bite. And the dosing is going to be based on the patient's symptoms. We're going to watch for any kind of necrosis and systemic changes. So now we have our toxicologic emergencies. This includes our alcohol, our acetaminophen, our amphetamines, and our opioids, and our foodborne illnesses. Okay, let's get on to talk about our toxicologic environmental emergency of alcohol, over alcohol intoxication and alcoholic poisoning. Symptoms of this one are going to be, I'm sure you guys are all aware, decreased muscle coordination, dehydration, hypoglycemia, hypotension, altered thermoregulation, the inability to regulate our temperature, so a patient may become hyperthermic. The patient might also have some lactic acidosis, where they're not joining in on that normal Krebs cycle, but participating in some anaerobic metabolism, which is not nearly as effective as our Krebs cycle metabolism. Patient might also have some nausea, vomiting, abdominal pain, some severe respiratory depression, tachycardia, they have seizures, and they may be quite confused. Variables that affect the risk of alcohol intoxication are going to be your height and body weight. The larger you are, the more muscle that you have, the more fat mass you have, the more there is the ability to absorb, and then effectively there's going to be less alcohol within your bloodstream because it'll be absorbed through those larger areas, muscle and fat. And then it also depends on our innate liver's metabolic rate. So some individuals just metabolize slower from the liver based on some inherent gene responses that they have. Whether the patient has a full or empty stomach can be a determining variable there. So food decreases the absorption of ethanol into the bloodstream. It also depends on the drink's ethanol concentration and whether there's other drugs present in the body and our ability to tolerate alcohol. So our chronic alcohol users have built up quite a tolerance and can drink more alcohol than those that are not as experienced there. So with our blood alcohol level, as you can see, we have we'll come up with the math equation for this, but basically a 20 equals 0.02%. So when you breathe, do that breathalyzer test, we're talking about 80 milligrams per deciliter in the body. If you have a breathalyzer, it'll be a 0.08. And the reason why I bring up 80 and 0.08 is because that's kind of legal impairment for most states there to be able to catch you if you're driving impaired. So at 20 to 79 milligrams per deciliter, the patient may have some impairment, some coordination issues, and they may have some euphoria, so feeling pretty good. They're disinhibitory response with our GABA receptor, right? And at 80 to 199 milligrams per deciliter, we're going to start having some issues. So the patient may become ataxic and exhibit some poor judgment, as well as have a labile mood. So happiness or euphoria may quickly go into a moody mood there. At 200 to 299 milligrams per deciliter, the patient is going to have some marked ataxia. You'll notice some slurred speech, poor judgment, labile mood, and they may also experience some nausea and vomiting at this point. 300 to 399. This is really actually technically called a stage 1 anesthesia. So it would be just like giving a conscious sedation to a person. They may experience some amnesia or blackout, have some memory lapse, and once again some labile mood, as well as all of those marked ataxia, slurred speech, poor judgment, all of that. And then at 400 plus milligrams per deciliter, the patient will undoubtedly have some respiratory failure or coma. When we are in the emergency department, sometimes we do a little, what's the highest you've seen type thing. 478 was my max, and the patient really didn't exhibit, all of these signs because they had quite a tolerance built up. That's where you'll see those high ones. Otherwise, they're in big trouble. So 100 milligrams per deciliter equals 0.1 grams of deciliter equals 0.1%. So that's how they get the breathalyzer versus blood alcohol there. Alcohol metabolizes at about 15 to 25 milligrams per deciliter per hour, so not too terribly fast. If the patient has a blood alcohol level of 150 or 0.15%, it would take them about 6 to 10 hours to quote unquote sober up. Our older adults have decreased metabolism and therefore will have prolonged levels of alcohol intoxication. Additionally, our older adults have comorbid conditions that may make them more susceptible to these untoward signs and symptoms. Our women have less alcohol dehydrogenase used to break down alcohol, so they may be experiencing less rapid absorption or metabolism of the alcohol, and their body water to fat ratio is higher, and this causes higher concentration in women. Binge drinking is considered a level of 0.08% or 80 within 2 hours, and that's about 5 drinks in a 2-hour period. Treatment for alcohol poisoning includes cardiac monitoring. Obviously, that's going to be huge. We're going to monitor their CMP, their ethanol level, or ETOH, and watch for any kind of metabolic derangement. As these guys are highly susceptible to a metabolic derangement. We're going to monitor their A's, B's, and C's, making sure that their airway is well supported by themselves. The provider might consider a gastric lavage, aka the pumping of a stomach, although I have actually yet to do this, and I can't really think of a time that anybody in the emergency department has done a gastric lavage or a stomach pumping on these people, but we can give them kind of activated charcoal, so that charcoal kind of soaks up some of the alcohol. We will be giving them IV fluids and some kind of nausea medicine to treat them symptomatically, such as Zofran. All right, moving on to acetaminophen. So an acetaminophen ingestion, whether it be intentional or unintentional, is the leading cause of acute renal failure, so greater even than hepatitis. Our persons with alcohol abuse or liver disease are at increased risk for toxicity because they already have some impairment in the liver there. It's very commonly overdosed. It's pretty easily accessible. It's found in a combination of lots of over-the-counter drugs, including lots of our cold medicines and headache medications. And I would like to go over with you the 3 stages of toxicity as it pertains to acetaminophen toxicity. This is our initial stage, which occurs at hours 0 to 24. Our dormant stage will be hours 24 to 28, or 48, excuse me, and our hepatic stage is 48 to 96 hours. Oops, okay, there we go. So our initial stage at hours 0 to 24, the symptoms are likely to be mild or moderate. The patient may have a little bit of GI irritation, such as nausea or vomiting, or just kind of an upset stomach. In massive toxic states, the levels can be greater than 800 milligrams per liter in 4 hours. So we'll get into that in a couple of slides from here. At our dormant stage, or 24 to 48 hours, the patient still kind of may have kind of some mild symptoms, but relatively symptom-free. So GI upset is what they're likely to have. But even though they're asymptomatic, stuff's a brewing within their liver, and liver failure begins. As a result, you'll notice a increase in their AST, ALT, INR, PT, and PTT. These will all increase. And like I said, the patient may have some right upper quadrant pain, which is specific for the liver there. In that hepatic stage at hours 48 to 96, there is going to be some hepatic encephalopathy. The patient will have confusion, lethargy, and even coma. There will be lots of vomiting involved, as well as jaundice and significant right upper quadrant pain, as well as coagulability issues, so lots of bleeding can occur. The patient may become hypoglycemic. They will no doubt have increased liver enzymes at this point, and we're going to run into a lot of kidney damage as well. Treatment for our acetaminophen toxicities are going to be our, initially BLS and ACLS report. We're going to obtain baseline labs, such as our liver enzymes and coag labs, as well as our acetaminophen levels. And I will get to that, like I said, in a couple, and I believe the next slide. The patient may undergo a gastric lavage, which I just mentioned was that stomach pumping, if the ingestion was recent and the dose was more than 15 extra strength tablets or 7,500 milligrams. We can also give activated charcoal to help absorb some of that chemical there. So another medication that we can give this patient is the antidote, which is N-acetylcysteine or Mucomist. It's done via inhalation or IV. And here as of late, I've only seen it in IV form or fashion, but in inhalation, they give it in as a nebulizer, and that smells like rotten eggs. So you know exactly on the unit what's occurring. If you smell rotten eggs, you're getting that N-acetylcysteine. But it's been quite a while since I've gotten to experience that lovely thing. And we should be really giving it within 8 hours of ingestion there. The patient might also have to go and undergo some hemodialysis to get, that toxic blood out of their body there. So here's these numbers here. So it's the acetaminophen level is in, the units per milliliter. So, nanograms per milliliter. Golly, I'm having some issues. And so the higher, the amount of acetaminophen, the level that's in their body initially, the higher their chance of hepatotoxicity there, especially at those, hours 4 to 8. So we'll take those initial labs, and then we'll take some subsequent labs at hour number 4, and hopefully we have quite a metabolism going on that's going to drop those levels to below 100 by hour 8. So it really kind of depends on our measures plus the individual's ability to metabolize. All right, let's move on to methamphetamine toxicity. Methamphetamine is a powerful, highly addictive stimulant that affects the central nervous system. Crystal meth is a form of that drug that looks like glass fragments or shiny, like bluish white rocks. It is chemically similar to amphetamine, a drug that is used to treat attention deficit hyperactivity disorder and narcolepsy, which is a sleep disorder, right? And but it's similar, but not not the same. We'll call it that. Other common names for methamphetamine include blue, crystal, ice meth, and speed. People can take methamphetamine in various routes, including smoking it, swallowing it, such like as in pill form, snorting it, or injecting it into the vein. Won't go into all of these things, but basically there's some really nasty stuff that you can find within our current methamphetamine. I just read a book about all the changes that the methamphetamine has made over the course of the last, 8 to 10 years, and it's really kind of gotten just worse and worse as far as outcomes of the patients there. They initially used it in World War II when they were giving it to soldiers to be able to go long distances, to be used as killing machines there. But in the past, a lot of things have changed with it that have really kind of changed the neurological status of the patient and their propensity for a psychotic event. So more on methamphetamine. Either ephedrine or pseudoephedrine is sourced illegally or extracted from cold and diet medications. A chemical reaction is created by adding either anhydrous ammonia and lithium or red phosphorus iodine crystals in water. Either method will create meth. A solvent is added to extract the meth from the waste, and bubbling acidic gas through the meth forms it into crystals, and we're seeing less and less of these like at home methamphetamine, meth mobile homes or meth houses, because it's just very, very cheap to get from China by way of Mexico right now. Okay, so if a patient has an overdose of amphetamine, we can expect lots of varying changes, including irregular breathing, irregular heartbeat, chest pain, heart attack, stroke, seizure, agitation, high body temperature, extreme anxiety, kidney failure, pericarditis, and right here is EKG changes for pericarditis. So you guys remember looking at those ST elevations for our patients with our myocardial infarctions, our ST elevated myocardial infarctions, or STEMIs. You probably did that with Christina, but in pericarditis, you are going to see these ST changes in every single lead, and that's going to be one of the clues for pericarditis, as well as that nice big old rub there that you'll hear when you auscultate, especially kind of at the PMI area. Okay, so our treatments for these guys are going to be our BLS and ACLS support, and then we're obviously going to just be treating the symptoms. There is no antidote, unfortunately, to methamphetamine. If they do have pericarditis, we could treat. Sometimes we have to take them to the cath lab. It's just the same as a STEMI, right? And then if they have any kind of arrhythmia, we need to be treating that as well. So some of the things that we should be noting with amphetamine, not overdose, but usage here. The patient will have sudden or severe weight loss. As a patient or, friend or family members, to keep an eye out on everybody. Notice some extreme perspiration, irregular breathing patterns, might be some nosebleeds, sores that are slow to heal, dilated pupils, burns, particularly in the lips or the fingers. Might notice some track marks on their arms if IV is the route of choice, and some blackened or rotting teeth, also known as meth mouth. They might also experience some broken teeth, so going to get a lot of mouth issues with a meth user. This results in meth-induced tooth grinding, so a lot of bruxism is what it's called, lots of grinding on the teeth there. You might also notice some bad breath and some premature aging of skin. So, in Oregon, they have created a website. I think they call it like the Faces of Meth or something like that. So if we're not scaring these patients off by all of these problems that they're having, if we can at least kind of hopefully appeal to some people's vanity, and just show them how a person can, rapidly age, just look awful, after just a short time on methamphetamine. But let's keep going. Other signs and symptoms include paranoia, anxiety, nervousness, agitation or fidgeting, mood swings, depression, hallucinations, or belief that there's insects crawling under skin, which lead to meth sores there. And just like I said, they have a propensity to even have a psychotic breakdown, have psychosis. Okay, on to the next one. We have our opiates here, right? So these are either found in prescription drugs such as morphine, fentanyl, hydrocodone, etc., and our heroin, which can be achieved through ejecting, inhaling, and snorting. And a lot of people that are getting heroin are kind of in for more of a shock because there's a lot of things that are locally mixed in our heroin, including that outrageous Mexi or fentanyl that you guys are hearing a lot about. It's just so widespread. It's just awful. In fact, I think we're seeing less heroin and more of those Mexis there, or fentanyls, and once again, it's just a lot cheaper and more readily available for the patient. So heroin can be injected, inhaled, or snorted, and really so can our prescription drugs. I've seen all sorts of methods for people getting that fast absorption there. Signs and symptoms of opioid toxicity will be our CNS depression, respiratory depression, and then the meiosis, or those constricted pupils. Symptoms of chronic use include those track marks, and there may even be some skin abscesses. A lot of our patients, unfortunately, will run out of vein access and then kind of pop the heroin into their muscle. They call it muscling it, and they end up with some pretty nasty abscesses that need to be, drained and given antibiotics for. And obviously, if you see any drug paraphernalia that's in that patient's possession, you can kind of allude that they're using. These guys are susceptible to hepatitis, and especially hepatitis C and B, and HIV there. Treatment for them is going to be our BLS and ACLS support. Oh, you guys noticing a trend? It's like on top of everything, right? Should be your first priority most of the time when you're considering things on your NCLEX review as well. And then we give Narcan or naloxone. One really nice thing about naloxone is that the Surgeon General of Washington State has made this a public order, so you can go into any pharmacy of your choice and actually obtain naloxone or Narcan. If we have like a neighbor or a friend or a family, or just want to be a good citizen, it's good to have it available. I've considered it in the past. I haven't actually done it. Get that order and have it available for me, or for the people I run into, I should say. We can give naloxone IV. We can give it nasally. It's really nice to use nasally because it's just easy to use, so it's nice for the population to be able to utilize. We have that as a, if in case of emergency break glass situation. So we have the Narcan available in our triage area of the emergency department. Duration of Narcan, however, only lasts about 40 to 90 minutes. So we need to keep these patients for observation, even though they're likely not to be very good friends with us afterwards. They typically just absolutely hate it when we give Narcan, because we're essentially ruining the good high that they're having, but unfortunately those opioids can last longer than the Narcan can, so we'll give that Narcan, and in 40 to 90 minutes when the Narcan wears off, the opioid is still there, and they can have that kind of rebound effect there, so we need to keep watching them right there. So Washington State, just like we had mentioned, has that Good Samaritan law. So if you seek medical assistance in a drug-related overdose, you cannot be prosecuted for drug possession. So we're not calling the cops if you seek that medical assistance there. The overdose victim is also protected from drug possession charges. So if you bring somebody in that's experiencing an opioid overdose, you're not going to be, your name's not going to get taken. You're not, we're not going to call the cops on you. We're going to hope that people will utilize the emergency department a little bit more. instead of dealing with these overdoses themselves. So anyone in Washington State who might have or witness an opioid overdose is allowed to carry and administer Narcan. Okay, I think I'm going to skip ARDS. You guys kind of gone through that in many of your lectures, but I would like to keep the slides for you guys to be able to look at, refamiliarize yourself with it. All right, we're going to move on to eye injuries. I think also during the Tools of the Trade, we did some really fabulous work in this area. And ones we're going to be going over are going to be our conjunctivitis, our corneal abrasions, and our retinal detachments. This is obviously an example of a retinal detachment. So our conjunctivitis, also known as pink eye, can happen bacterially, virally, fungally, can be as a result of allergic reaction or as a result of a chemical contaminant. Signs and symptoms of this one are going to be our eyelids are going to be kind of appear crusted shut upon awakening. There might be a sensation of the foreign body in the eye. The patient will also experience some redness of the conjunctiva, as well as if the patient has purulent drainage, especially in one eye, you can kind of consider that it's bacterial. The patient with a viral or allergic conjunctivitis will have some serous drainage, and this is likely to affect both eyes in our allergic situations, and then followed by both eyes in our viral situations. The patient might also have some itching of the eye, and then during their allergic conjunctivitis, and some photophobia, or not really appreciating that light there. Treatments include, if it's allergic, we're going to try to minimize that allergic response for the patient. So give them an antihistamine there. We're going to administer antibiotic drops or ointment if it's bacterial there, and cool compresses. If it's chemical related, we're going to do an eye irrigation, just as was demonstrated by your peers. Patient education, bacterial conjunctivitis is highly contagious. We should consider frequent hand washing, social isolation, so no school until they're cleared and their eye is clear, no swimming, no handling of food with an infection, wear sunglasses to decrease that photophobia, and absolutely no contact lens wearing until they are clear of that infection. All right, moving right along, we have our corneal abrasion, which your peer had discussed with you in a very thorough detail there. This is the most commonly seen eye injury, and it's caused by a foreign body scratching the corneal epithelium. Signs and symptoms of this include pain, photophobia, excessive tearing, and that sensation of the foreign body, as well as potential eyelid spasms there. Treatment for these guys, as you remember, we're going to use a proparacaine or procainamide ophthalmic solution into their eyes. We will not be giving the patient this proparacaine, as it causes pretty good vascular constriction, so overuse can be really impactful for these guys, and can cause permanent damage, but so easy to overuse that because the numbing drops work so well. We might also use a topical ophthalmic ointment with a non-steroidal anti-inflammatory. We don't give opioids to these patients. Typically if the corneal abrasion is severe, they might need an ophthalmology consult, and This is the fluorescein under the woods lamp that was explained to you guys already. Retinal detachment is a tear in the retina which allows vitreous humor to leak between the retina and the choroid, diminishing blood supply. May be caused by trauma, likely caused by trauma, or sometimes not. Retinal detachment is more frequent in nearsighted individuals due to the retina being thinner from our myopia. Signs and symptoms include a flash of light. The patient might also have floaters, or what they call looks like cobwebs in their visual field, sudden decrease of loss of vision, kind of a reporting things like a veil or a curtain that's affecting their visual field. This is an emergent condition, and we will need to be referred to the ophthalmologist for immediate intervention. And if left untreated, the patient can have permanent vision loss. All right, epistaxis, also known as bloody nose. This is bleeding from either the anterior, like I said, that's a huge area, or posterior nasal vascular. Our posterior nosebleeds are going to be hugely profuse and more common in our older patients or older adults. The causes of likely anterior nosebleeds are going to be from nose picking, nasal trauma, inhalant use. Flonase is kind of one of the ones that gets a lot of credit for that. Dry nasal mucosa, hypertension, infections, tumors, septal perforations, intranasal drug use such as like snorting cocaine, anticoagulation use, or any kind of coagulopathy that a patient might have. This is going to be bleeding from one or both nares, dizziness from severe blood loss, nausea, vomiting from swallowing that blood. Treatment is always BLS support and ACLS support, so I'm going to try to prevent that patient from getting any kind of blood into their airway. Elevate that head of the bed, have the patient sit upright, lean forward, and pinch that nose. We could even use one of those clamps, those handy dandy clamps that we learned about, right? We might give IV fluid support if the bleeding is severe, as well as, blood support. The patient may have chemical cautery, so patient may use a little silver nitrate on a localized bleeding site, or they can have nasal packing. We do use in the emergency department cocaine, which can help minimize that bleeding there. We might also use something like a rhino rocket that was described in our tools of trade. All right, we get to go on to bioterrorism. This is required for your content in nursing school, and so we will go over this. This is a bioterrorism attack is the deliberate release of a virus, bacteria, toxins, or other harmful agents used to cause illness or death in people, animals, or plants. We have our category A's, which are going to be these highly disseminated. These are going to include our anthrax, botulism, plague. More on that in a minute. The plague in a minute, and botulism. Smallpox. I don't even dare talk about what that is. Tularemia, and viral hemorrhagic fevers such as Ebola. And our B are going to be not as widely able to be disseminated there. They result in a low mortality rate and require enhancement of diagnostic and surveillance capability. These are going to include our West Nile viruses, hepatitis A, our ricin toxin, salmonella, and our diarrheagenic E. coli. And our category C are widely available. They're easily produced and disseminated and have a potential for a high mortality rate. This includes our influenza, SARS, rabies, multi-drug resistant tuberculosis, yellow fever, and any kind of tick-borne hemorrhagic fever. I'll talk to you also about the bubonic plague, which is very rare at this point in time. But, you know, an outbreak can come at any moment there. This is an enzootic vector-borne, so it's going to be go from a animal to a human by way of a vector. So in this case, infected rat a flea will bite it, and then a flea will bite a human, and so that's how it gets transmitted. And this is the second of the world's most devastating diseases in years past. It is caused by Yersinia pestis, which is gram-negative bacillus. The patient will have flu-like symptoms with easy septicemia, pneumonia, meningitis, hepatic and splenic abscesses, and lymphadenopathy. And this has actually been used as bioterrorism, where they'll drop fleas into an area or into aerosolization, which can cause this widespread of it. Then we have our botulism, or Clostridium botulinum. That's readily available with a toxin released in areas of low oxygen and higher levels of temperature, which is why we can get it when we can inappropriately. Homemade canning, like such as green beans and such. So it can come from IV drug use, a mishandling of food, just like I talked about. It can be iatrogenic. We give Botox for many different things in the hospital setting, and you can actually get a Botox toxicity due to some of these various methods that we use, and it can occur via bioterrorism. Botulism is a neuroparalytic illness characterized by symmetric descending flaccid paralysis of motor and autonomic nerves. So it'll go descending. It always begins with the cranial nerves. So the patient's not going to be able to, move their face very well, or eyes, swallow, things like that. Signs and symptoms include diplopia or double vision, blurred vision, ptosis or drooping of eyelids. That's going to be a cranial nerve 7 or the facial nerve affected there. So they'll have slurred speech, dysphagia or difficulty swallowing, and dry mouth and muscle weakness. We need to give them lots of supportive care there. And then I want to go into malignant hyperthermia. This is caused by a mixture of a mutation in the RYR1 gene, followed by an altered calcium channel release. And it occurs in the presence of a triggering agent such as a volatile anesthetic such as acetylcholine. So this mutated channel will open more easily, the calcium channel, and then it stays open for longer. And then it floods the cytosol with calcium. So we're going to have this massive flooding of these calcium channels. This results in a high intracellular level of calcium, which stimulates sustained muscle contraction or rigidity. It also stimulates breakdown of glycogen, glycolysis, and aerobic metabolism, resulting in excessive production of heat. So that's where the hypothermia comes into place. Everybody that works in the emergency department needs to know where that malignant hyperthermia cart is, because we are giving people that causative, that triggering agent. So we give someone succinylcholine to do a rapid sequential intubation, and all of a sudden now they're not able to speak for themselves just because we gave them this blocker, right? And so we need to be highly vigilant, especially if the person has a family history of malignant hyperthermia. We need to be aware of the potential for causing that malignant hyperthermia. We want to give dantrolene. It's a lot of dantrolene. This is the medication that's going to stop that calcium channel from opening there, and it's high doses. So it's 2.5 milligrams per kilogram IV every 5 minutes. So lots and lots. We should just be drawing up as much dantrolene as is within that cart, because we're likely going to be giving it lots of dantrolene, and we may need to repeat that dose. We might also give some sodium bicarb for suspected metabolic acidosis. That one's going to be slow IV push, and that's also found in the malignant hyperthermia cart as well as our code cards. The patient may also be getting some insulin, calcium gluconate, or calcium chloride for any kind of hyperkalemia that is occurring. And that is all I have for environmental emergencies. Thank you, guys.